Here we present our poster about SLC35A2 CDG as a differential diagnosis of Mabry syndrome, report of 2 Brazilian patients in a diagnostic journey. SLC35A2 CDG is caused by mutations in the X-linked SLC352 gene, encoding UDP galactose transporter, leading to a hypogalactosylation of any glycans. It is characterized by early onset and refractory seizures, developmental delay, and abnormal brain image findings. There is substantial variability in clinical symptoms within this group of patients, maybe reflecting the type of mutation, the level of mosaicism, or the degree of X chromosome inactivation. Some reported male patients are mosaic for this mutation, suggesting that this disorder may be X-linked dominant and that males must be mosaic for since the beginning. Another point, Mabry syndrome comprises a triad of seizures, hypophosphatasia, increased alkaline phosphatase, and intellectual disability due to the defects in the glycosyl phosphatidylinositol biosynthetic pathway. It usually manifests in the first year of life with severe developmental delay and tonic-clonic seizures in most of the patients. In both disorders, skeletal manifestations can also occur along some dysmorphic features. As we can see here in the GPA anchors defects, most of those defects involve the ER, and they are not detected by isoelectric focusing. And in our cohort of patients, we decided to present 2 cases that were misdiagnosed as Mabry syndrome, but in fact has CL35A2 mutations. We presented 2 female patients in a retrospective clinical neuroimaging and laboratory data review. Our patients were female and showed global developmental delay with hypotonia. Seizures in both of them started in the first months of life. Abnormal electroencephalograms were seen in both patients, showing features of hypsarrhythmia. Seizures were refractory to all antiepileptic drugs tested so far. Clinical evaluation showed dysmorphic features like permanent forehead, widely spaced inverted nipples, strabismus, small hands, and apparent proximal shortening of arms. There have been tests for all other metabolic disorders with measures of lactate, carnitine, CK, vitamin B12, and even performed chromosome microarray to exclude microdeletion syndromes. They did more than once the IF, transferrin, and the MS for CDG that are both normal. Increased alkaline phosphatase were constant in both patients, although with a trend toward normalization along the time. Brain magnetic resonance findings included cerebral and cerebellar atrophy, thinning of the corpus callosum, and increased cerebroventricular. Sequencing of all genes associated with Mabry syndrome and GPA anchor disorder was normal. So we, as the last result, we did the whole exome sequencing, confirmed that they both had de novo mutations in the CSL35A2 gene in both patients. And this is one of the brain MRIs showing progressive brain atrophy with some white matter changes in periventricular areas. We can conclude that elevated alkaline phosphatase in Mabry syndrome is related to its pathology, physiopathology, since defects in GPA biogenesis, they affect the expression of the anchored proteins like alkaline phosphatase, as it is an anchored protein. And in the case of SL35A2, we know that most females are affected, but they have a wide range of manifestations expressing the random X chromosome inactivation that can occur. And both disorders cannot be capped by doing transferrin or abnormal total serial and or all glycan profile. So most of those cases, you need to do a next-generation sequencing to identify the mutations. Increased AIP, although not specific, can be a clue to SL35A2 CDG diagnosis, especially in the absence of other biochemical findings. Furthermore, patients by clinical diagnosis of Mabry syndrome, but no mutation found in GPA genes should be screened for SL35A2. Since because this patient with SL35A2 mutation, they can have both dysmorphic features. Here's a patient's Mabry syndrome, and they can also have skeletal abnormalities as well. So since there's this overlapping and alkaline phosphatase can be increased in both disorders, we point out that patients should be screened for the SLC35A2 when they are excluded of all genes involved with GPR anchors biogenesis. Thank you very much.